Hello everyone, a warm welcome to today's webinar from IIB, and this is IIB's EBUS certification course. It gives me great pleasure to invite you all to this very unique and innovative online EBUS certification course, which is an initiative of IIB, our Indian Association for Bronchology. As you all know, IIB is our national body of IP, and the IIBGC would like to facilitate maximum IP training for one and all with this very unique and unprecedented online EBUS certification course. We are bringing EBUS learning to your doorstep. The EBUS certification course will consist of 10 online modules, each focusing on very important aspects of EBUS in great detail, taught and discussed by the greatest experts in this field from our country. At the end of these 10 webinars, we will have 4 physical workshops on 4 different Sundays, one in each zone of the country, north, south, east, west. And those people who have attended at least 8 online modules and those who will attend at least one live physical workshop will be able to get the certification EBA completion degree. So basically the thing is that we've kept 4 different workshops so that people can decide to attend whichever is closest to them, or if they happen to miss one that is close to them, they have a chance to go to another one. But to repeat, to get a completion of certificate, to get the certification completion of this composite and enriching academic activity, the participants will have to attend at least 8 webinars live, and they will have to attend at least one physical workshop at the end, and at the workshop they will be conferred upon the certification of completion. The highlight of the certification course is that all the important EBUS aspects will be covered in detail. Normally, whenever we have a workshop, we have lectures for 4 hours where everything is covered. Over here, we are going to have actually 10 into 2, about 20 hours, which will be dedicated to every important aspect of EBUS. And the best thing is that during the workshop, we will only have hands-on, and therefore everybody will get to really know EBUS theory well and will also get to learn the procedure absolutely in detail. So with this brief introduction, I would like to first thank IIB Governing Council for the huge support. Dr. Mehul in particular for helping tremendously with this entire preparation of the thoracoscope of the EBUS certification course. I would like to thank our academic partners, Mankind and Olympus, especially Mr. Manoj and Mr. Nitin from Mankind, and the entire team of Mankind for helping us disseminate this information to everybody. And with this, I think we can start our first webinar, which is about EBUS Essential Patient Selection and Preparation. And now I'd like to invite none other than the best and the biggest expert, the most popular, absolutely the wizard of EBUS. I'd like to invite Dr. Jai Chandra, who's our moderator. I'd like to invite him to take over. And Dr. Jai Chandra requires absolutely no introduction. The entire country, I would say entire world knows him as one of the top interventional pulmonologists who has actually been a pioneer. I mean, he's been a pioneer of thoracoscopy. We all know the first person to start thoracoscopy in our country, and a fantastic academician, a great interventional pulmonologist, and a brilliant, brilliant academician and a dear, dear friend. Can we have a slide, please, tech team? Okay, so just as a formality, we all know Dr. Jayachandra. He is at the Banjara Hills, Hyderabad. He is the director and head of the department, senior interventional pulmonologist, also at the Care Hospital. And as I said, he's been one of the pioneers of IP in our country. And over to you, Dr. Jayachandra. Please take over. Thanks.
Thank you. I think that you just went overboard with my introduction. Thank you, nevertheless. Okay. Now, I think this is going to be a very interesting session wherein we want to start off on EBUS and all the things which go with it. And I know this is part of an extended session on EBUS. But today, I think it is very, very appropriate that we start the entire session with one of the pioneers of EBUS in the country. Look at Patabi. I mean, I've known this guy for a long, long, long time. But all credit to him that he was one of the first to start EBUS in this country. Way back in 2008, if I remember, he went to Japan, he got trained there for an extended period there and came back fully armed with the knowledge and the instrument to start this particular modality in interventional pulmonology. Now, whether we put it as a part of interventional pulmonology or not is a different thing altogether, because this has become basic pulmonology if you want to do an EBUS. So I think we need to have his slide. This is to formally introduce him. He's a consultant and an interventional pulmonologist at Royal Care in Coimbatore, visiting professor in SRMC Chennai. He heads or he's part of an interventional pulmonology group in Royal Care with two other people. And between the three of them, they do a tremendous job in pulmonology and in interventional pulmonology. As I mentioned, he was the first to do EBUS in 2008 and bronchial thermoplasty 2017. I don't know whether that's a creditable thing or not, but anyway, that's besides the point. He's got multiple articles on IP, and he's been an invited speaker in all the national and some international conferences where he gives his talks about his experience and tells people, teaches people how a procedure needs to be done. And I'll tell you one thing, his way of putting things across, which you will hear now in a short time, he gives you the basic fundamental thing about the procedure that he's talking about. I will not stop him any further. I think he should start this talk right away. And I'll tell you one thing, all of you are going to be very, very rich after this experience of listening to him. Over to you, Pata. Pata, you can take over.
Yeah, thanks. That was again, it's your turn to embarrass me. Yeah. So thanks, Amita, for putting this together. And Jay, I mean, being a friend and a mentor, the same thing. It's really huge to have, all the introduction. And now let's just move on. Hope my slides are visible.
Yes.
This is going to be about 20-25 minutes. This is going to be about the brief of starting EBUS. And so this was in 2008, November 11 in Coimbatore, 58-year-old lady with a history of CA breast, had a 4-hour note. That was the first patient who had, endobronchial ultrasound TBNA in India. And this was our old EUC 60 processor. We were the only group to have it. And after that, it became EU ME1. So even Olympus, most of the people in Olympus wouldn't know this. This is a dinosaurial processor here. And this is the first generation needle. And so we've come a long way. Next 20 minutes, it's just going to be about the scope of the procedure. We just discuss the indications, the routes, anesthesia, sedation, challenges and precautions. It will just be very editorial. And I'll just give some idea about how it was set in our place and what needs to be done in terms of setting up a program. This will not be the necessary order in this. And, first we'll have to salute this surgeon from Argentina who a rigid bronchoscopy, put in a needle straight into across the carina blindly and made a diagnosis from a mediastinal lymph node in 1949. But all the credit to Professor Kopanwan and in part to our own Dr. Atul Mehta. They just did the TBNA, the conventional one, for both diagnosis and staging. And look at this. This is the first manuscript from them, 1983, 39 patients, 11 were for staging. Imagine 1983 and so many patients for staging. Look at their numbers. Amazing numbers. And you'll also have to understand the CT was not performed in every patient. So they look at this X-ray and they just think that there is a lymph node based on the X-ray and they go ahead and make diagnosis. Now, that is remarkable. So you can see that it's only wizards can do that. And so there was a gap in the mediastinum. This was blind area. This was owned by surgeons and at times by radiologists. After the advent of CT obviously improved the understanding. Surgeons were the absolute owners initially. Subsequently, with the advent of radial probe guide sheaths and then convex probe EBUS in that order, gave the pulmonologist the ownership. It took close to 30 years from the time that CT happened. And as in every thing in interventional pulmonology, it started with the GI people. GI people developed the EU scope, and subsequently, there is about a few years lag, which will be the time required for the scopes to get smaller, which is the miniaturization, improvement of optics. That is the time taken between the GI. And then once that is developed, there was no looking back. So basically, an endobronchial ultrasound is a scope which is a dedicated scope with a transducer. So you can use the scope only to make diagnosis. And diagnosis not inside the airway, anything outside the airway. So the typical ones are the lymph nodes which are strewn across. And these are the ones that gets enlarged in a specific conditions, most common being granuloma or a malignancy. In India, in that equal proportion. In Western, it's more of a malignancy than granuloma. And you can see that the lymph nodes are, I wouldn't really go into very, very basic details because these are all available. So you can see groups like a 2R, 2L, 4R, 4L, 7, 10R, 11R, and so on. So this is upper and lower paratracheal, subcarinal, and hilar lymph nodes, which are very important in terms of staging our malignancy also, apart from, showing up whenever there is either a tuberculosis or sarcoidosis or other rare conditions like, you can have a lymphomas or you can have a pericarditis, you can have bronchogenic cyst, you can have many other things that can happen around the airway. Now, and not to forget that the lungs are in close proximity. And if you have a lung mass which is medial, which is having some kind of connection with the airway or a contact with the airway, EBUS can be used as a standalone method to shove a needle into the mass and make a diagnosis. We also see there are a lot of blood vessels, and initially blood vessels were supposed to be the ones that we look and then ignore or move away because we don't want to puncture them. Subsequently, in 2013, Felix Herth and the group showed that you can actually diagnose pulmonary embolism because the pulmonary artery has a course which runs along the airway. It starts here, it divides into the right and the left, and it has a very close proximity right till the division of the segmental arteries. And so the major segmental pulmonary emboli can be seen now. Why is that important? From 2012, 2013, where Felix Herth had put out that paper in respiration, now recently, Professor Yasufuku in Toronto, who was there in Chiba earlier, now in Toronto, now they've now looked at whether you can use EBUS to thrombolize. This will be, as a replacement to a catheter-related thrombolysis. The couple of papers, phase 2 trials are on. Phase 3 is now getting started, and they've now successfully done in animals, and the pig pulmonary embolysis, where emboli were actually lysed fairly successfully. So that space is getting watched. And then also the nodes that were not in contact were not being used by endobronchial ultrasound. So the station 8 or 9, which are paraesophageal, are not are not reached by EBUS. Whereas a typical lymph nodes are station 2 and 4, which are paratracheal right and left, 7, which is subcarinal, 10, 11, 12 are hilar lymph nodes. So these are the ones that are accessible by EBUS. And those do not have or share any contact with the airways are 5, probiotic, 6, paraiotic, 8 and 9 paraesophageal. These are the ones that you don't use EBUS in conventional term for a thing. Now, subsequent lectures in subsequent weeks will tell you how to, take care of these borders, but that is not the purview of this particular thing. So for a starter, these are the nodes that are not, used by endobronchial ultrasound. The most common nodes are 7 and 4R, and to an extent 4L. So you can see if you can sample these two, these are actually, thankfully, quite easy nodes to sample. And if you can actually tackle 4R here, precarinal and paratracheal, lower paratracheal, or clubbed together as 4R, or a subcarinal that's beyond the carina, and a 4L, which is the left paratracheal, if you are able to sample these three, which are actually good if there are big nodes, you can use a conventional TBNA to use those. So these are beginners nodes, so that you can practice on this for a start. 5 and 6 are the ones that are not actually in our purview, at least in the basics. So What does it take to set up a EBUS service? Now let's look at it. If you have a need, is there a need in conventional term, in scientific terms? Yes, but is there a need in your place? Is what something that you'll have to think about. And you should have a good OP service which can support your own procedures, or you should have a good referral systems. You should be a part of a multi-specialty because there might be a physicians who want to refer for any intervention, be it a pleural effusion or a mediastinal node. You'll bank on other people, especially the physicians, oncologists, and you'll also have to work out economics because
Yeah,
these are going to be very, very costly. Now, the time that we bought our EBUS,
okay.
the first one in 2008 was 1 crore. Now it's a lot less and there are a lot more of options available. But you'll have to understand that there will be a lot of added recurring costs, including the needles and so on. So you'll have to really think about all this before embarking on such a program. Acquiring skills, there are two components. One is the bronchoscopic skills. Another one is a TBNA skills. And the most important, the other one will be ultrasound skills. Now, ultrasound, there is not much actually. It's basically a beginner's ultrasound only. You see a dark black whenever you see a blood vessel. You see air, you don't actually see it. And if you see anything gray in major scales, will be nodes. So you'll just have to have a few things to differentiate one from the other, and maybe to run a Doppler, which is going to be very basic need. And if you are not colorblind, you should be all right with that. So bronchoscopic skills is the most important thing. And if you have aced conventional TBNA skills, I think that is all that is required. There are much of training avenues now than ever before, and you can actually knock any of these training avenues with permission, obviously. And the good thing is the simulators, these have been game changers. You have good simulators available and you have good hands-on workshops. And Amita has now put together this with the IAB, and that's also a thing. And the ACCP thinks that if you do 25 e-buses and to maintain 10 per year, but again, these are just numbers that has been taken out of nowhere. And so each people will be different. So you'll have to, learn by using at least 25 to 50. But to maintain skills, you'll need to have, more than 10 every year. So that is about the basic thing, whether you need to do it at all, or if you think that your area or if your scope of practice will allow you to start this program. That is something that you'll have to think about. And subsequently, you'll have to think about how you're going to do it. Now, EBUS is ideally done in a bronchoscopy suite, which is a dedicated suite. But you can also do it in a shared suite with the gastroenterology colleagues. The advantage being you can use the same processor. Only thing is they'll be a lot busier than we are in terms of procedure. And so you might get a 6 a.m. slot or a 9 p.m. slot. So that is something that you'll have to haggle and hassle. That is something that you'll have to think about. Or you can do it in a theater. So these are the three areas, but you'll have to have a proper monitoring area and equipment. And it is always nice to start off when you have your anesthetist colleagues, anesthesia colleagues helping you. You can technically do it with sedation, with a local anesthesia. However, to start off, I would strongly recommend you to go with an anesthesiologist. What will be the route you will use? A typical bronchoscope is a nasal procedure. So it's a 5.7, 5.9. Oral procedure is ideal for EBUS because the scopes are slightly bulky. It started off with a 6.9. Now it's around 6.4. Again, a pentax scope will be bulkier. So you'll have to think about the outer diameter, which is a maximum diameter. Now, Indians, especially South Indians, they have a smaller nose, especially the female. So we usually use the oral thing. In Delhi, in the AIMS, Karan Madan and colleagues, they've shown that at least 70% of them, they can manage with nasal. So I think depending on where you are and the build of the nose and the massive and the other anatomical thing, you can actually use nasal. The advantage of nasal is you don't have a problem of having a bite block and constant worry of the patient biting the scope, which is the most important complication in our setting. Bite block is very important. However, if you have an anesthetist, that is the best thing. You can have a laryngeal mask airway or any supraglottic airway like a iGel. So the size 4 or above is ideal. And if you have an anesthesiologist, you have to start off, is ET tube okay? It should be size 8.5 or more. I'll tell you why. Or you could use rigid bronchoscopy as done in certain parts of Europe. But we would advise you against using a rigid bronchoscopy. That's a little bit of an overkill. But I'll tell you what a problem is when you have an infraglottic conduit. Now, you'll have to think about a few things. Now, effect of bronchoscope size. Normally, bronchoscope occupies only about 10% of trachea and EBUS maybe 12%. The concept of double obstruction happens when you put in a ET tube or a rigid bronchoscopy because those will occupy the lumen. Bronchoscope will just add on to it. The adult bronchoscope is 5.7, EBUS is 6.9 to 6.4, depending on the generation you get. These are the sizes of endotracheal tube 9, 8, and 7. You can see that luminal obstruction, when you use a 7, forget it, you can't shove an EBUS tube in. 8 is difficult. 8.5, you'll still have around 30%. So this is for a bronchoscope of 5.7, you can still see that about 2/3 is gone when you put in a 7 mm scope. But if you put an EBUS, even in a 9 mm scope, more than 50% of the lumen will be obstructed. And the dictum for the ET tube should be at least 2 millimeters larger than the bronchoscope. This 6.5 means 8.5 at least. And if you have a 6.9 scope like what we have, it should be 9. And tell me the number of people who can actually take a 9 mm scope. Cross section of all these things. So you have a cross section of a trachea like this. You have an endotracheal tube. So a trachea is 2 centimeter, endotracheal tube 8, and a bronchoscope is 6. So you can see all put together, what is the effective area of ventilation? This happens in a very small portion. The rest of it is not available for ventilating. Now, that is a serious problem. You will have a effective ventilatory area of 0.22. Remember this, and you add a supraglottic airway like an LMA. So instead of endotracheal tube, you have an LMA. You can see that the bronchoscope occupying only about 10 to 12%, and you can see that's 2.82, which is a 1,200 times or 1,200% increase in the area of ventilation. So we would advise not to use a conduit like an endotracheal tube. Supraglottic airway is always useful when endotracheal tube instead of endotracheal tube in any bronchoscopy, more so in EBUS. Why more so in EBUS? You might have to sample a node here or a node here. If the endotracheal tube goes all the way here and you have a scope coming out like that, you can do it only for hilar and the maneuverability will be a lot lesser. Whereas if you use an LMA, you can see the whole area and you can actually sample all the nodes in the top. So more scope maneuverability happens with the laryngeal mask airway. So ideal would be to have a deep sedation or a conscious sedation with an anesthetist all around, or you can do the sedation by yourself with a liberal dose of a lignocaine. We would, our initial few years, we've been using only conscious sedation, but once we switched over to GA with the anesthesiologist coming into our place, we actually had a lot easier thing. We could go after smaller nodes, patient don't cough at all, patient will be lying like that, and so that it helps in 2 things. One is it improves our performance in terms of making a diagnosis. Also, since ours is a teaching institute, we'll have fellows who can actually concentrate on the procedure than the patients because there is someone else who's taking care of that. Now, if you have to, in a situation where you can't have anesthesiologists coming in and there are a lot of logistic issues, so this is not the only way to do it. You can pretty well do it under deep sedation. In parts of Brazil, only topical lignocaine without any sedation is also being practiced. So you could use, even in a lot of our thing, when I said Brazil, it's in the context of, they even did a bronchial thermoplasty in one such institute, doing purely on a topical lignocaine only. So in India, there are a lot of places where only lignocaine has been used, but it's usually advantageous to have a good sedation because we don't want the patient to cough and remember this procedure. Again, topical lignocaine is very useful because it's a prolonged procedure. So there are sedation considerations which has to factor in the thing that it's not a lavage, it's not a just go brush and come out. It's a procedure which might include a patient doing, if you have a rose, it's going to take some time. If you do a staging, it's going to take a longer time. We would advise anesthesiologists. However, we can also do it with a liberal anesthesia. AIMS, again, Karan Madan and colleagues have shown a transtracheal puncture is very useful in EBUS rather than spray as you go. Again, we also love that if you have to do it on our own, we use a transtracheal only. May need multiple modalities, not only EBUS, especially in sarcoidosis, we might have to do an endobronchial biopsy, we might have to do transbronchial biopsy, end up with a lavage and so on. Post-procedure monitoring, because there is a larger dose of sedation that's required. So patient might take time for, things. So that is something that you'll have to factor in. It's not that you come in the morning, do the procedure and get out. you have to ensure that there is a place for a monitoring post-procedure and make sure the patient completely is awake. May need more local anesthesia, transtracheal installation is beneficial. So let's look at the indications. Now, this has been the whole indication for EBUS. The most important being the cancer. For cancer, we have a lot of things to do, just not enough to make a diagnosis. That is 1980s, 90s practice. These days, the oncologists are more demanding, patients are more demanding, and it's our own responsibility to ensure that the small samples have to be given in a certain way so that the pathologists don't complain. So you have a lot of things. It's not enough to make a diagnosis between non-small cell and small cell. You'll have to make sure that it is immunohistochemistry is done. You'll have to run a few, NGS testings or PDL1 because all these are druggable mutations are available. There are a lot of fan medications which has actually improved the survival in lung cancer for the first time. This decade has seen improvement in the life expectancy. NGS is now being talked about everywhere. In mesothelioma, you'll need a lot more of tissue, and extra cancer diagnosis will have that much more of immunohistochemistry to see what is the cell of origin. Sarcoidosis, obviously, a granuloma detection stage 1 and stage 2 sarcoid. Again, we'll also use the multiple modalities, not only the EBUS TBNA. In tuberculosis, we'll send one pass for cultures, both for PCR and conventional cultures. Mediastinal cyst, there is a cyst detection, and if the cyst is causing compression, you might put in a new needle once and not more than that, and remove the fluid that is available under antibiotic thing and careful monitoring. Lymphoma is a bear, as far as EBUS goes. We might high-grade lymphomas, you might identify it, but lymphoma is not a diagnosis as a NHL or a HL. You'll need to, again, a lot more of things that needs to be done. So the newer techniques in EBUS, which you'll be seeing in subsequent weeks, have actually transformed the way we diagnose a lymphoma. But as far as conventional EBUS TBNA goes, just for a primary subtyping and recurrent detection, it doesn't do too well. But you'll need to know that it is out there. If there is a suspicion, you might have to follow it up with either a cryobiopsy or a mediastinoscopy. So that will be discussed subsequently in other lectures. When you talk about suspected extrathoracic cancer, you can see that this is about the metastasis from a primary elsewhere. A sensitivity of 85%. Negative predictive value is 95%. That is especially if you add immunohistochemistry. So different trials have given us a very good specificity and a reasonable sensitivity as well. As far as sarcoidosis go, 80%. There is this Van Bertel study which said 53% to 80%, but our PGI group have clearly shown that you don't need an EBUS scope. So what if you want to diagnose sarcoidosis? We don't have an EBUS scope, no problem. If you do a combination of a endobronchial biopsy and transbronchial biopsy along with a lavage, and they compared it with a combination of a transbronchial biopsy, endobronchial biopsy, and EBUS TBNA, and they just compared with a conventional TBNA, there has been no added benefit if you're using EBUS as a combination. But as a standalone, EBUS seems to have the highest yield. But again, we started using and we continue to use EBUS TBNA. Only thing is we'll also added endobronchial and a transbronchial biopsy. Now, how many passes in sarcoidosis for people who are EBUS exponents? They clearly know that the sarcoidosis, especially if you have a rose, you'll understand that you'll need to have more passes to get a granuloma, because some of the sarcoids, they're very sparsely exfoliating the granulomas, and so it might take time. So you'll have to use at least 4 passes, and after that it plateaus. So that is something that you will have to understand. If you suspect sarcoidosis, use at least 4 passes, and from all the nodes that are big and are involved. In tuberculosis, you'll also obviously combine with the PCR expert and expert ultra. Gene expert ultra is very important, along with the regular cultures and histopathology and cytology. Lymphoma, there's one paper which included 22 needles, 5 passes per lymph node, and close to about 77% sensitivity, which is huge. There's a very low sensitivity in all the other things. Here they included cytopathology, immunophenotyping, and the flow cytometry from cytology samples. It's a tall order, not every people will be able to do it. So this cannot be extrapolated to a regular EBUS TBNA. So whenever there is a lymphoma, you'll have to use either a mediastinoscopy or there is a recent interest in mediastinal cryobiopsy. I'm sure it will be discussed subsequently. Now, what are the cases where you wouldn't want to do a EBUS? It is as much as any contraindication for other bronchoscopy. Hypoxemia that can't be optimized, patient doesn't consent for the procedure, unstable cardiac status, recent myocardial infarction, and patient with unstable hemodynamics, and an untrained or untrained operator or an untrained team. Now, the most important thing is the untrained team. So those are the people that we'll have to have, we'll talk about the contraindication. Precautions, I'll just, this is the last couple of slides. Precaution is, one is about clopidogrel, because most of them above 50 is now on clopidogrel, and some special situations which will be discussed in detail subsequently. So I'm not going to get into details of pediatric EBUS or transvascular EBUS or EBUS TMBCB, which is transbronchial mediastinal cryobiopsy. This is a different topic. I'm sure pediatric and transvascular is discussed. So all these special situations will have to be, the most important precaution is to do all this, you'll have to have completed at least 100 EBUSs on your own. So I wouldn't want you to do this, as a start. So you'll have to get a good skill set, both you and the whole team, before embarking on any special situations. Now, clopidogrel is an important thing, so I'll just spend a couple of slides more on that. It's to avoid in all cases where biopsy is planned, especially in TBLB. So clopidogrel in bronchology, in TBLB, we don't use it. No robust data in conventional TBNA. Logic is be careful if the nodes are small. And there are all other aggressive intervention needs the stopping of clopidogrel for 5 to 7 days. And it has its own risk, so you'll have to talk to the patient and his cardiologist. Now, what about EBUS TBNA in clopidogrel? Remember, I'm saying EBUS TBNA, this cannot be extrapolated to transvascular pediatric or EUS BFNA or even a mediastinal cryobiopsy, because there are no data. Here, there is a RCT. EBUS and clopidogrel has been found to be reasonably safe. We have all done EBUS, ultrasound FNAC from cervical FNAC has been proven safe. In fact, 8F pleural drainage is safe in patients on clopidogrel. Strater and group from Canada, they said that in a series of 12 patients, there is no bleeding risk. But there was also a prospective RCT which happened to look at this particular thing. Patient having a routine clopidogrel use on bleeding complication after EBUS, 40 patients, 22 gauge was done for 3 passes, and they actually look at the difference between the 22 gauge and the 21 gauge. So they did 22 gauge first, 3 passes, and there are no bleed. They just looked at 21 gauge and did the three more passes. And all these patients were on clopidogrel. 92 nodes were done. No significant was only one patient had some who was needing 30 ml of normalcy. Cold slide. So that is as far as clopidogrel is concerned. So for a regular EBUS TBNA, clopidogrel, you don't need to stop. So what are the components? So ultimately, you've known about the basic stuff, indication, contraindication, precaution. If you think that we can start this, if you think that you got a good referral system, if you think you work in a multi-specialty hospital, if you think your system is in place, team is in place, you have good referral base and your employer is not going to bother, look at other components. You'll need a benevolent employer who is willing to invest in you. You need a broncho suite, ideally with an anesthesia support, because the EBUS TBNA procedure is long and you will need an anesthesiologist so that you can concentrate on the procedure. You should have helpful colleagues. Economics for both initial and maintenance, everything should be included. For us, every case of EBUS, we actually segregate an amount that we'll charge the patient for scope cleaning. We charge one thing for needle and for repair. So all these 3 components should be factored in when you prepare a bill for a patient. And you should have a relationship with vendors, and Olympus has been extremely nice to us. I'm sure Olympus, couple of them are here. So this is just to keep them in good humor. But it is true, they've been very, very nice, because the loaners are very, very difficult to come by. Because now in India, there are enough numbers, and so the loaners are difficult. So you should ensure that you use all the proper precautions and don't damage the scope. And for that, you need to have a team who understands what is happening. So the scope, if you are trained, is not enough. The scope should be handled in a certain way, and you're not the only person who's going to handle it. The teamwork is all the way. Both the tech and the nurse support is vital. The most important component is go around. If you start, don't stay and then start go around different centers with good volume. All the people who are doing this in a thing, I mean, there are few here also who would be talking, and all the other persons who are going to start for the next 9 weeks or so. All of them are quite okay, reasonable people who will actually allow you to come and shadow with them for a couple of days, at least to see what their perspectives and how it is done. Once you do that, and such programs like the one that is organized by IAB will definitely help you in understanding what it takes to start off with things. So, because when you start well, I think that is a job at least 50% done, and rest of it is how we go further. So I'll be happy to answer any questions probably at the end of. Obviously there will be a panel discussion to have more experts to follow. With this, I'll hand it over to Jay for further.
Sir, perhaps you're mute.
Sir, you're on mute mode.
Okay, sorry. My mistake. Anyway, thank you very much, Pata, for a very concise and a precise talk on EBUS, which had an overview of all the procedures. I mean, the entire procedure, the pros, the cons, and the important aspects of EBUS before you start this particular practice. Now we have a eminent group of people who will sit down with us, and we will have a discussion and we'll take questions. I have prepared a set of questions which I would ask some of our panelists to answer. And if you have any questions which need to be answered, you can just send it across and we will try to cover as many as we can. Now, let me introduce the panel. I think it's my proud privilege to introduce Sandeep Nair. He's been a friend for how many, 20 years plus? Yeah, whatever. But the basic thing is he's the principal director and head of the department for Center for Chest and Respiratory Disease at BLK Max Super Speciality, New Delhi. I mean, he has had a significant amount of interest in interventional pulmonology, working with another senior colleague of mine. And he has gone on to train himself in Marseille, for both for IP as well as for thoracoscopy and other things. Also in sleep medicine, I see. But apart from all this, he's been a very, very dedicated pulmonologist offering his services to people of Delhi, and I think who respect him considerably. So he's one of the senior ones who's with us, and in an order of seniority, let me go on to the next panelist. May I have the next slide, please? Yeah. Dr. Unnati Desai, MD Pulmonary Medicine from Mumbai, Fellow in IP from Italy. Present position is Professor Additional and in charge Pulmonary Medicines in BYL Nair Hospital, Mumbai. She's got multiple presentations and publications and member of IAB, ICS, ERS, ISDA. I don't know her personally, so sorry for a very brief introduction. But anyway, I think she's one of the first people to have started EBUS in the public sector.
In Mumbai.
In Bombay. I think that's a very creditable thing.
Thank you.
Unfortunately, Bombay has been lacking in this particular thing, but welcome to the club, Dr. Desai.
Thank you, sir.
So next in line would be Dr. Devraj, if I have not mistaken. May I have the next slide, please? Again, now the next person is Dr. Devraj. As I said, we are going by seniority. So he's the third one in there. Qualifications of MD, DNBM, and DM, Pulmonary and Critical Care. And he's the head of the department, Pulmonology, Manipal, AMRI, and Medica, Kolkata. Awards of ERS Gold Sponsorship 2013, Silver Sponsorship 14 and 18, and Apollo Young Clinician Award 23. Areas of interest, interventional pulmonology, that's why he's here anyway. Pulmonary and critical care, and mostly airway diseases. Publications are more than 55, organizational post, member of GMA editorial committee. Welcome, Dr. Devraj, from my side.
Thank you, sir.
Let's have the next one, please. Dr. Nishita Singh. Oh, pleasant looking lady, yeah.
Executive Director, Senior Chest Consultant at Asthma Bhavan, Jaipur, member of the prestigious steering group of Global Asthma Network, delivered talks both at national and international levels, specialized in various procedures, have pioneered EBUS in Rajasthan. That's very good. More than 30 of her research papers have been published in renowned journals like ERS, ERJ, and New England Journal of Medicine, member of ILD, Indian Registries, National Coordinator Team. She has been awarded the Dr. S.K. Sarkar Best Research Paper Oration Award 2019, Indian Chest Society, and Best Lung India Publication Award for publication on EBUS at NAPCON Kochi 2019. Welcome to the show. And
Thank
now
you, sir.
I think we will get on with the questions that I have prepared, and I'll direct them to some of you, and I would appreciate an answer, brief answer, and we can have any further questions or spin-off questions which arise out of that, and we will let any of the panelists to take it depending on their own experience. Of course, with Pata being there, he's the super expert in this particular field, and he may have to contribute in some of these things. So the first question is, what are the pre-procedure investigations normally advised before EBUS? This goes to Dr. Sandeep.
Thank you, sir, for having me here and asking me a question.
Let's have Sandeep on the screen, please.
Yeah. So, see, basically, if you read the EBUS, it's just a standard bronchoscopy. So, all those investigations required for a bronchoscopy, we normally get it done for EBUS also. Take a good history, take a routine investigation. Here, one of the most important investigation, of course, turns out to be a CT scan. Of course, Pratapi showed a beautiful paper by Wang et al., who did a FNAC without even getting a CT scan done in only the X-ray. But in the present scenario, you need to have a CT scan, one of the most important investigation when we do a when we do a EBUS, because you need to know where the nodes are present, is there any necrosis, where are you going to hit it, how line, and this is we normally always get it done. Of course, there is always a challenge, or there is always something which is always a gray area, whether you do a routine coagulation profile or not, because there are studies to show you may not do in a perfectly healthy patient, do it only in those patients who are having bleeding diseases, etc. But I normally get it done for my patient as a routine investigation. I normally get it done when my patient comes to me, coagulation profile, at least a PT INR also. And when you take a good history, of course, you tend to know whether the patient is on a CKD or a CLD, and is the patient of CKD when was it last dialysis was done, because many times they push in heparin, so you must be very careful when you're taking a patient. You also take their previous history of a COPD if they are there, because you're worried about giving them more sedation if they are a CO2 narcotic patient. So, see, these patients, they will come to you with bulge of investigation mostly, and you have to pick up the right ones and take a detailed history, take a comorbid condition, and accordingly. Basic requirement, of course, a routine investigation, including a CT scan. I do a coagulation profile. You need to know your platelets value and the CPC. And of course, like I said, that any past history of any reaction to the drug, because that again comes to important, or the comorbid condition like diabetes, because you have to give them instruction accordingly when to come to you for the EBUS.
Yeah, I think that was very concise in what you said. So I'll ask Dr. Unnati another question now. Tell us about the patient preparation for EBUS with fasting, stopping antiplatelets, oral anticoagulants, and low molecular weight heparin. I think clopidogrel was covered extensively by Pata, but the rest of it you take on now.
Yes. So, sir, we already have guidelines, the bronchoscopy guidelines by the IAB, ICS, and also the EBUS guidelines. So, as per these guidelines, usually for the procedures of 4 to 6 hours, fasting is enough. But all of us, we know as a rule, we keep an overnight fasting for the patients, and usually it's the first procedure done in the morning when we have bronchoscopy and advanced bronchoscopic procedures posted in our IPSU. So, usually an overnight fasting is preferred. The guidelines say 4 to 6 hours of fasting is enough. As far as aspirin is concerned, it is said that you can hold an aspirin if it is not indicated. So we have to see the risks versus the benefits of the aspirin that is necessary. And if we need to hold aspirin at least 3 days prior to procedure. Now, the EBUS guideline by the IAB-ICS has also said that low dose aspirin of 75 milligram may be continued in patients who are at risk and who need to be on the aspirin. So this is a statement that they make in the guideline. However, as a rule, we try and stop or switch over to drugs like heparin or low molecular weight heparin, which can be stopped 24 hours prior and have a safety cover for the patient. As far as the novel oral anticoagulants are concerned, it is said that they have to be stopped 2 days before the procedure. And yes, cover up the NOACs with a conventional heparin or a low molecular weight heparin, which can be stopped 24 hours prior.
Thank you. That's very concise. Dr. Debrajna, when you plan for an EBUS, do you want a patient to go through a formal pre-anesthetic evaluation by the anesthetic the previous day, or do you have on the table, you will ask the anesthetist to have a look because you have already evaluated the patient. You just ask him to come and help you out and be there and take on the case almost immediately. Your thoughts on that?
Sir, ideally, because also we need to consider, because EBUS is a diagnostic procedure, so the cost of the EBUS and to convince the patient for a PSC and to come one day separately for a PSC checkup and to have a battery of tests. So practical point of view, it has to be an individualistic call depending upon the patient. Ideally, the pre-anesthetic checkup always is ideal. But on a practical basis, when you are convincing the patient to undergo an EBUS test, and on top of which you need to do a echocardiography, you need to do all other additional tests, and also to come the patient for an additional PSC, it is little bit difficult. However, in certain subset of patient, when you are expecting the patient to have certain cardiac comorbidities, so exclusion of those cardiac comorbidities, taking additional precautions during the procedure, and also particularly in certain COPD, because in mostly done in malignant patient, in particular subset of COPD patient like who is on BiPAP or home BiPAP or has a tendency or history of type 2 respiratory failure admission, on those patient doing an ABG, those kind of setup. So it is a call which will be made based on the patient, should be vary between patient to patient ideally, but certain basic tests we are already doing at the time when we are prescribing the EBUS test to be done.
Okay. So I think that's a very fair way of looking at it. And you don't always have to ask the patient to come the previous day. That's fine. Because as physicians, we always evaluate our own patients. And we know the high-risk people. And only those people will be referred for a more formal evaluation by the anesthesiologist before you take them on. Fair enough. That's okay. I think then Dr. Nishita, I'll ask her a question. What kind of anesthesia do you normally prefer for EBUS? Total intravenous, GA, or have you ever done it under local anesthesia? Advantages, disadvantages of each of these choices that you make when you are asking for an EBUS or when you're planning for an EBUS?
Good evening, sir. First of all, it is an honor to be sitting and having a panel discussion with such esteemed faculties. So regarding the EBUS, well, the time we started doing EBUS in the year 2016. At that time, we did the EBUS in mild sedation. We did not have anesthetist facilities at our center. So we were giving the patients lignocaine and with midazolam, finargan combination, glycopyrrolate combination. That was how we were doing and proceeding with our procedures. So early on, the procedures went on well. The diagnosis yield was also sufficient enough. But later on, certain roadblocks came into our procedures, especially when the patient started demanding. So that they were having some issues with they were frightened of the procedures. And that was the time when we first contacted our anesthetist and he came into our OT. So that was the time we took the patients under moderate sedations and with the agents used preferably was propofol in combination with dexmedetomidine and ketamine. So this was a combination that we are using, and that is the total intravenous anesthesia that we are doing under moderate sedation. So preferably, if you ask me my personal choice, then I always advise the patients to go for like some kind of a mild sedation, because that also suffices and does the job, and the patient is so uh, conscious and well oriented right after the procedure. But still, you have to look at certain aspects, as especially looking at what do you want, and if the case is going to run for a longer time, if it is a high risk patient, and what is the patient preference. Because adding an anesthetist, although it smoothens the entire process for the patient, but it also adds to the cost of the procedure. So looking at all these aspects, if the patient is well to do and able to bear the cost, then definitely moderate sedation is much more comfortable to the patient.
Okay. Have you ever heard of a thing called mom and pop rule? No, I don't think so. But anyway, I'll tell you this thing. This is a
Sounds very interesting.
This is a choice that what choice would you take when you're getting it done for your mom or pop? All right. So it's not a question always about cost, local anesthesia, general anesthesia, intravenous anesthesia. What is the most comfortable for the patient? I think probably that deserves some consideration in all our discussions. Though this is a non-medical answer, I thought this is something which I'll just slip in to make you think about these aspects when you plan the next procedure. Okay. Now, there's
Very
another question.
sound and heartfelt advice. Thank you, sir.
Okay. Okay, now next to Patabi, I don't know. He's already answered this question in quite some detail. Do you use LMA for all your patients, some patients, or never? What are the difficulties? What are the advantages foreseen? I think he's already talked about it. And this
Yeah, but I think I'll just spend a little bit on what I did not talk about in these situations. One is, this is, I mean, LMA obviously means that the anesthetist comes into place, which actually means that there are only certain places that it can be used, in the institutes where anesthetists are available and they're willing to come to your state. So it actually, I mean, anesthesia and sedation practices would be completely individualized, customized to what the thing is. So the few things into consideration is, if you are working in a public thing where you don't have a room for recovery, patient has to necessarily get back home. You can't use a lot of sedation. So there will be a cut corner kind of situation. It will not be applicable for everyone. Having said that, if it is going to be for a diagnosis of a single solitary big node, then you would do away with all these things and just have a liberal anesthesia and a liberal local anesthesia and a little bit of a sedation, and then that should be okay. But in our place, I mean, I wouldn't advocate this that this should be the way, but in our place, it is always done under with an anesthetist thing, and which usually done with a LMA. For the reasons we don't use any conduit, for the reasons already told, but LMA is always whenever we think that small notes, staging, having a rose, all these will prolong this procedure. So when you are including all this, you ensure that you concentrate only on the procedure. And for that, the best person to concentrate on the welfare of the patient while you're doing the procedure would be an anesthetist. So my thing is very clear. In our place, we'll do it because it's available. Anesthetists come to us. And of course, it's going to be costly. So those are the things that I'm going to say. It's a very, very qualified statement. We would do everything under an LMA, excepting when we are planning for an EUS BFN. That is the only time where we don't want a LMA. There is also another thing called as a esophageal LMA. That's very useful because it will direct you directly to the esophagus, and the patient will continue to be ventilated, if you like. But we don't use that because it's something that's not going to hurt the patient. So very minimal sedation or no sedation, you can actually gulp this tube in because it's a small EBUS scope. So these are the considerations. So what is the population? Where is the setup? What is the indication? And What is the, how is the patient monitored after? All these are the factors that needs to be looked at. In our case, almost 90% of the patients who undergo EBUS in Royal Care will have an LNA. It's usually a size 4, size 3.5, unless it's a pediatric. So that's the.
Yeah, I think that's very, very concise. And I think that's very, very, very valuable tips, that it is always easy to do it under LMA, unless it's, as he said, a single node, and it does, the anticipated time for the procedure is just about 10 minutes or 15 minutes, in which case you can go ahead with a local anesthesia. That's fine. Now, Sandeep, is there a critical oxygenation drop anticipated? How do you tackle the tip in the planning, and when it happens? How do you take care of it?
See, normally the hypoxia can occur in any patient. Honestly speaking, a patient can suddenly go into spasm and the patient can have hypoxia. But those patients who have got low FEV1, who should have done pulmonary function test prior to it, and these are more likely to be done. Though I can, like I said, it can go in any patient. The hypoxia can occur because, but I will beautifully showed that how that bronchoscope, though it is calling only 10% of the section, but still if you're taking a to a pure conduit, it will further compromise the your lumen. Having said that, of course, you are a bit skeptical in giving high oxygen in patients who have got COPD or a type 2 respiratory failure in past, because you don't want hypoxia to be knocked off. So you maintain the oxygen somewhere around 90% only. And but other patients, of course, you do oxygenate because there is a fall in the saturation whenever you are doing they were doing a procedure. And anyone where is going to prolonged hypoxia means more than 1 minute, especially where the saturation falls than let's say 90% or more than 4% of whatever the baseline of the patient had it. If it's fall in these patients, you definitely need to supplement with the oxygen. So whenever you're taking them, these patients, you always have a oxygen standby with you, and you always be ready because most of the time you're giving them the nasal cannula, so you don't can't lift your the head out, putting a nasal cannula when you're already doing a procedure. You already pre-op before doing the procedure, you already give them a nasal cannula, whether you give it 1 liter or no liter, but at least prepare them when doing an EBUS. And most of them do require a little bit of oxygen when you're doing a procedure because deep sedation will further cause hypoxia. All these patients are compromised, their lumen is compromised, they can be bleeding when you're doing an EBUS. So all these things can cause hypoxia in these patients.
Okay, thank you. I'll go on to Dr. Unnati. GA versus controlled sedation. What percentage of your patients need a full intubation? Please elaborate on each of these things. I know you come from a different setup, so probably it's very relevant that you answer this. And I'm sure you're going towards sedation, but anyway, let's have your thoughts on this.
So, sir, it's like as it has been discussed. So, in our setup, sir, we've seen isolated mediastinal and hilar lymphadenopathy of tuberculous etiology or suspected tuberculous etiology to be more than 50 to 70% of the cases referred to us. Unfortunately, cancers don't come to us early, wherein I need to really do the staging. So it's like it is predominantly this patient group which needs diagnostics for a suspected tuberculosis, or rarely there's a sarcoid. So, sir, currently what we have been doing is we use intratracheal lignocaine and we use mild to moderate sedation. Yes, having an anesthetist would be really great, but again, sir, there are constraints. At our institute level, we have OTs, major procedures, and a lot of things, but we are working towards it. Our US colleagues already have had roped in anesthesia, and we plan to move in next to have one or two of those patients where we counsel who doesn't cooperate, and yes, not having the memory of the procedure would be really great for the patient. So as of now, we use intratracheal lignocaine, and lot of liberal topical lignocaine in the procedure to suppress the cough, and use sedation, midazolam and fentanyl, so that the cough is suppressed, the patient is comfortable, and when there is a station 7 or a node around the esophagus, I use a EUSB, which is more comfortable as compared to an EBUS that way. So this is how we go. So as of now, 1 in 10 patients, sir, I have to cancel or probably, refer to my EUS colleagues, wherein they have, an anesthetist and everything available. So 1 in 10 patients, but these are predominantly suspected tuberculous lymphadenopathies.
I think that's a very, very fair approach, because not everybody has got a bronch suite like what Pata has got. I mean, he's got a fantastic state-of-the-art bronch suite. So where he can, command that the anesthetist is there and he's got a whole lineup of procedures to be done. But then on the other side, you're working in a government institute where you're catering to a different clientele altogether. Resource is rather limited. I think you're doing a great job in doing it under local anesthesia.
Thank
I
you.
think that's the basic message I think that should go out. Don't depend that you'd have to do everything under GA. It can be done under this thing with some sedation. Exceptional cases will require general anesthesia. That's fair. But I think what your approach is very, very good.
Thank
So let's look at Dr. Devraj's answer to this. Role of muscle relaxants for EBUS, in which patients, which agents, and why? Dr. Devraj.
Sir, we seldom use muscle relaxant for EBUS. Seldom use muscle relaxant for EBUS procedure because most of the time with the help of propofol, midazolam, or fentanyl.
So it is not an essential drug to be used for EBUS. It is not required. That's okay. You disappeared from the screen. I can't see you. Anyway, let's get on to the next question, Dr. Nishita. Which is the preferred sedation? And what problems do you anticipate with each agent? Are you wary of propofol-induced hypotension?
So, as I said before, the type of anesthesia that is to be given depends upon the institution. It depends on what the doctor prefers as well as what the patient preference is. So, regarding the drawbacks and side effects of the various drugs, so few agents that are commonly used during EBUS, one is midazolam, then propofol, then
No, go on. It's okay.
so propofol is very much preferred during EBUS, and it is associated with hypotension and as well as respiratory depression. So propofol has got a very quick onset, fast onset, a short half-life, and its course is also very predictable. So it is quite a favorite amongst the anesthetists during EBUS procedure. It is associated with hypotension. So this problem is dealt with giving it in slow doses initially, and later on, as the dose is increased, the parameter is observed and monitored properly. And it is also associated with respiratory depression. And respiratory depression is another thing, and that is to be monitored with capnography and pulse oximetry. So similar kind of respiratory depression is also seen with midazolam, and the other agent dexmedetomidine is also, we commonly use it. So it does not have any effect on the respiration of the patient. So that is why it is very much used. And I think yes, that is it.
Okay. Fair enough. I think you need to look after something else there. That's okay. Now, Patak, what is the kind of topical anesthesia do you prefer? Okay.
So,
Role of
yeah,
lidocaine in all patients or selected. You already mentioned Karan
yeah,
Madan.
lidocaine, yes. Yeah, lidocaine 1%. Lidocaine 1%. See, usually, typically, when you do EBUS, you also first do a regular bronchoscopy. Conventional bronchoscopy will always be done before endobronchial ultrasound. And while you're inspecting, that is the time that you can actually anesthetize the patient properly. and we use the 1% lignocaine because that will give the safety margin a lot better. And because EBUS, we can't anesthetize properly with the EBUS because of the 30-degree forward and stuff, so we can't really concentrate on stuff. So that's why we do a proper thing. So lidocaine is done. Root is after Karan's paper, even before Karan's paper, when we were trained in it, I'm sure you will be, you would have been trained. With the yeah. So we also in our thing 1995 and stuff. This is very popular transtracheal, and after that spray as we go took over, and now I think it's coming back after Karan's paper, which is he's a very strong advocate for a transtracheal. Very strong reason also. There's a lot less of a cough when you use a transtracheal thing. So now once we have an anesthesiologist, I don't. I can't proclaim myself as a expert in all these because the anesthetist kind of takes over. So I would, people like Dr. Desai and they will be the much better, or Dr. Singh would know about these drugs much better than we do. We've kind of pampered group who slowly that part of the sedation part of the brain has come down now. We just as the anesthetist do the work, and so a local anesthesia is never, even if the patient is, quite, it's ideal to properly to the maximum. So that is, you have the maximum dosage also. I would advise every young pulmonologist to know about that. Again, I just wanted to tell this about when we were discussing about stoppage of drugs also, the ATS recommendations are very clearly out there. What we do is just take a picture of that and put in our bronchoscopy suite so that there'll be a ready reckoner for anyone who wants to do that. So most of the things are available. I want every junior doctor to know. And a quick thing, though I know I'm digressing, about the EBUS, TBNA, and clopidogrel. It's ideal if as a beginner, it's ideal to stop EBUS. Clopidogrel for EBUS also. But my only point is it's not mandatory. It's ideal but not mandatory because the studies have shown. So I think, and avoid nasal route. So these are the things. I know I'm just moving back and forth, but these are the points that I would also add along with the local anesthesia.
Points well made. There's no doubt about that. Sandeep, let's have you to describe a typical EBUS suite. Monitors, crash cart, what is it that you would want? This is quite obvious because you're going to do it in a bronch suite. Almost all the things that are required for a bronchoscopy would be required for an EBUS. What's special about an EBUS suite?
Yeah, before we have a luxury of previous suite point which Pratapi said, and that's what we all did. We started doing our EBUS. In fact, we were bronchoscopy with our gastro colleagues. With a bronchoscopy we started with it with our gastroscopy colleague, and even for the EBUS where they were doing EUS, we were doing our EBUS along with it because we had to share a processor. Well, they were doing more than 8 to 10 EUS at that time, and we were doing 1 or 2 at early morning or late afternoon, exactly what Pratapi was saying. Now, if you really want a good EBUS suite, if you're got a luxury of getting it, if your hospital gives you it should be a large room actually, say about 30 to 70 meter square room, and where you have, of course, a bronchoscopy table. Along with it, there should be enough space on the head, and in fact, it should have enough space for 3 of us to stand in. One of them is doing a EBUS, the other one is putting in a needle or helping you out in it, and at times you even have an anesthetiist standing with you because we share the head and most of the time. We should have a good processor on the left side and the screen is just right in front of us. I think we always do it from the head end. I think most of us are doing it for EBUS. So we normally have a screen on the say on the right or the left of the patient at the other foot end, so that is easily accessible to us. Whenever we're doing a bronchoscopy or a EBUS, we always have a crash cart ready with us, which has all the resuscitation measure. We have a laryngoscope, ET tubes, and everything. The crash cart is always available out here. We need to have a monitor, a very important thing, because we have a constant monitoring of the oxygen, SpO2, as well as the pulse, and as well as we have a BP cuff also on the patients, because the continuous monitoring when we are doing EBUS. So all those things which are required in bronchoscopy is required in an EBUS. In addition, we may have if we have a luxury, we may have a fluoroscopic availability at your center, and your table should be compatible with the fluoroscope, because especially when you're doing a radial EBUS, when you need to have a guidance from the fluoroscope. Well, then, having said that, it's not always easy to have every parameter in your suite, but as many as possible, we should go for it. And many of us, like I said, are sharing with the US, so we need to have we take more precaution about the cleaning, because our EBUS is even more sterile procedure as compared to the gastro people out there.
Okay. Dr. Unnati, now comes the interesting part.
One second, sorry. Interestingly, 1 second, sir. I just forgot. We need to have a negative suction in the our suite, and it should have at least 30, say, 12 to 15 exchanges per minute. I mean, that is also important, especially when we are dealing with the patient who may be infected cases.
Okay, I think that's a good point. I think it has not been mentioned by anybody so far. Dr. Unnati, the knobs, the settings, how do you do all this? How do you get a good image?
So, sir, when I started off with the EBUS, the first thing that scared me was the machine. And I have learned that it is just a machine, and we know the basics. We know the basics. We have been doing blind TBNAs, so it is just beyond the basics. So first and foremost, the switch on and switch off. Second is you connect the probe and ensure that the probe is shown as connected, because a lot of times you will realize that the probe is not connected to the system. And subsequently, once the scope is negotiated, we need to know the clinical and the radiological correlation. As ultrasound or radiologists teach, that you should predict or expect what you are going to see. So as the scope is negotiated in the airway, yes, keeping the scope as close to the airway as possible, as sir has already said in his talk. And on the knobs, the most important ones is the depth and the gain, because I need to see my structures properly. And then when the color dot, these three knobs are the ones which we use the maximum once we've negotiated the scope and we are in the lumen and we are seeing on the lymph node. So it is the depth, the gain, and the color Doppler. So these three knobs. In addition, there may be additional features like elastography, which may be used occasionally. But to get TBNA done, we need to know how to use these knobs, and they are just simple knobs, buttons. We should ensure that the machine that we are buying, we are trained for it in medical languages. Like when a patient comes to us, the patients expect us to tell them the disease in their language. We expect that the company engineer should teach us the machine in the language that we understand. Until we don't understand, we don't leave them, or we do not certify them that this installation is complete.
Yeah, the reason I included this question was that one gets completely scared when you look at all the buttons and other things go awry, especially when you're doing the procedure halfway through. Suddenly there are a whole lot of shadows coming in. You can't image properly. Yeah, I think that is the basic thing that you need to learn. You need to be a part technician, EBUS scopist, if you want to be a good EBUS scopist. Okay, probably that's the main point I was trying to make there. Now, Dr. Devraj, what are the ideal accessories needed to do a routine EBUS procedure?
Sir, before going to this question, last time my line got disconnected. So the question you asked regarding the muscle relaxant. So we seldom use muscle relaxant, only in doing while in a pediatric population, and also in patient with lot of comorbidities with a refractory bronchospasm. In those kind of patient, in sometimes a duration or short-acting paralytics help us in achieving the optimum hemodynamics. Only those kind of settings probably we use muscle relaxant, and apart from that, we hardly use muscle relaxant. So now coming to your question regarding what are, can you repeat the question, sir? Once again, sir.
What are the ideal accessories needed to do a routine EBUS procedure? Accessories.
So regarding the yes, sir. So regarding the accessory we require before doing the process.
Your audio is fading, doctor. We're not able to hear anything at all. I think we'll skip that. We'll make him join us later when he comes on. To Dr. Nishita. EBUS needles are disposable. Yeah.
Yes, sir. So actually, the network is very patchy, sir. So the EBUS needle, which is an absolute, and we need to check whether needle is functioning well. So this is one thing which is absolutely necessary. Needle. Number
Dr. Dev,
there
I
is
think your
the
voice
monitor is there or not.
No, there is a lot of audio disturbance. We are not able to make out what you're saying. I think you just fix your audio and come back. I'll give you time at the end of the entire this one. We can go back then.
Am I right now?
No, your voice is still breaking, Doc. Voice is breaking. So I think we'll just hold on. Fix your audio and then we'll come back to you. So I'll ask the next question to Dr. Nishita. All these EBUS needles, fancy needles that they're all disposable. Do you reuse them? If you reuse them, how many times do you reuse them? And how many times can you use the same needle? Advantages, disadvantages, and everything which goes with it.
So, sir, when we started doing EBUS, this was like some hidden question and that was there in the back of our mind. So we were like really confused because we could not raise the cost of the procedure to the patients, and the one needle was costing so much. According to the ideal conditions, one needle is supposed to be used on only one single patient. It is not to be reused, but that was not what we do practically. So practically, it is not possible in the Indian scenario. So we generally tend to reuse it in at least 3 to 4 patients. And this is a pitfall that is related to EBUS. So what we generally do is we sterilize the needle, and that needs a thorough sterilization process. But that is something that we have to like befriend it whatsoever its drawbacks are.
Yeah. What are the drawbacks?
So drawbacks is getting a false positive report, like doing you have conducted the EBUS test in a patient, and some cells still remain there, and if they are like TB positive, and then you do it on the other patient, and then that result come out to be positive.
Cross contamination.
Yes, cross contamination. So these things we do like keep in our mind that these are lacunas. And
how about the needle getting blunted?
Yes, the kinking of the needle is definitely yes, sir. And so the wear and tear of the needle. So after like 3 procedures, the needle is not in a good condition to be reused again. So we have to discard it.
And let me share one little secret that Patabi told me when he went for training for the first time, way back in 2007 in Japan. After every pass, they would dispose of the needle. Yes. For every pass, they would use a new needle. Well, yes. Never going to get there. We are the guys who want to reuse these needles a few times. 4 to 5 times seems to be a fair
That's
answer.
like a guilt that lives inside.
No, you don't need to feel guilty. You don't need to feel guilty. Absolutely. Only thing is you ensure that they are cleaned properly, they're sterilized properly, they're autoclaved properly, and everything is done properly, then it's okay. People will still complain that, yes, sometimes you have a problem with cross-contamination, you have infected the mediastinum and all kinds of things come up, but you still reuse. Let me make it very clear. Make sure. Pataba wants to say something. Yes. You're muted. You're muted.
Yeah. So there's a paper from PJ. That's the only one thing that can, give us some legal standing in what we are doing. So their paper, they reused only once. And they found out that there is a reduction in the yield between the new needle and the old needle. And the way they sterilize is something that needs to be followed to the T. And the 4 is if there is a TB, they don't reuse. I mean, if the first one is a TB, they don't reuse those needles. So I think there has to be some kind of a nuance in how we reuse also. I mean, now we are into JCA and all that, so we don't reuse needles anymore. Our EBUS rates are costly, but again, as I said, sitting in our place, we can't really say that this is how we have to do. But it's ideal to follow what is out there in the literature so that that is giving us some kind of a legal protection. Is to follow that paper. I think Ritesh and the group has given a thing, and that's also made to the guidelines. So EBUS guidelines, if you read, they'll say that it is advisable not to. And if you have to reuse, these are the things. So for the young postgraduate or the one who's starting out there, first thing is try not to reuse. Try to use a single thing every time. Add that to the thing, and the patient has to pay for that, obviously. Second thing is if you have to reuse, which I suspect will be, and all of us have reused. I mean, let's just not make a big thing out of it. We all reuse, but again, try and follow the procedure for sterilization. Don't reuse it. Tuberculosis patients, I think. So these are the things. Be very, very obsessive about the scope cleaning and handling things. So that is the most important thing in Indian situation. And you'll have to follow the manufacturer's thing to the T. It's not that, I mean, I can see a lot of conferences, they ask, how do you handle the scope? I would say that, I mean, Olympus actually does a workshop for the staff on a regular basis, technician course. I think you'll have to get your staff and the whole team enrolled to it and make sure that they do the whole thing and let there be no let up in terms of, I think it's our responsibility. Right.
But the next question, do you routinely do a flexible bronchoscopy before an EBUS?
Yes, we do.
So, yeah, you did mention that.
Yes, we do.
Particular advantages?
Two reasons. One is, of course, to have, I mean, the mucosal changes cannot be appreciated as much by the hybrid scope as much as you can do it with the video scope. We can anesthetize it properly. There are a lot of secretions. We can clear that upfront so that the EBUS process would be easier and doing it only for the purpose of doing an EBUS. So we always do it. And again, a lot of times CT might not show up and suddenly you might see not only the nodes, but there are also endobronchial changes where you do that procedure and the EBUS is not required. All these reasons we do the EBUS upfront. I mean, the regular bronchoscopy upfront.
Sandeep, next to you. Number of people that you require with you to do the procedure, assistants, I mean, and what role would you want to assign to each one of them?
So minimum 2 with you. One, of course, will be taking care of the IV fluids, etc., and other along with you. But you may need more if the anesthetic is there. Anesthetic will be there, and if you're doing a rose, a pathologist will be also there. Will be doing. Will be seeing the slides. If you have a luxury of a pathologist with you, you can do those along. But at least to do assistance, you definitely require who will be helping you in assisting the program. And like I said, one will be taking care of the IV line, who will be taking your orders, giving a sedation. And like I said, if the anesthetic is there, of course, half of the things are taken care of, like what Pratapi is getting the luxury. But we are not doing all procedures under anesthesia. We don't get anesthetist with us. We do under local anesthesia most of the patients. And here we have one more, my colleague and the staff, who we are 3 of us are doing most of the thing together. And we have our technician who is making us slides at the same time. If the pathologist comes to us, she sees there and there itself, but if not coming, at least he rushes to the pathology department and tells us there is adequate material, so that we know what next to be done, whether we are continuing the more passes or we are what we have to do next.
Okay, fair enough. Dr. Unnati, next to you. How do you process your samples, materials for sample preparation and processing?
Yes, sir. So, sir, the basic first making the cytology slides. So, our pathologists insist for air dried as well as alcohol fixed slides. So, like 2 air dried and 2 alcohol fixed slides minimum they would want to get the cytology report. We are thankful to our pathologists to give us really good, but cytological reports and have helped us even in tuberculosis where the bacteriological reports have been negative. Yes, then subsequently, because most of my patients are tuberculosis suspects, I send a sample for gene expert AFB culture. It is sent in a single container and labs process the same sample. They centrifuge the sample and a little bit of a sediment is taken for the gene expert and the rest is processed for culture. Now, as the sir has already mentioned in his talk that EBUS is done everywhere basically for staging, and there would be a lot of things in cancer that would be needed. So then samples like where I've been trained in Italy, they would send samples for IHC, for molecular typing, and for further tests. And they would be having this little bits, but the pathologist would give them wonderful IHCs, molecular markers, and everything, whether it's a lung cancer or whether it's a lymphoma, whatever it is. So yes, samples for cytology, immunohistochemistry, the molecular markers for what the primary disease cancer is suspected, and in tuberculosis and in infections, gene expert, AFB culture, and if we are considering some rare infections, then for those cultures.
Thank you. So, Dr. Nishita, what about the post-procedure evaluation? What to look for? How long would you want to observe them before you let them go? Devra, thank you. Welcome back.
Yes, sir.
I'll give you the next question. Just give me a few minutes. Let
No,
Nishita answer this and then we'll go back to your question.
So the post-procedure follow-up of the patient is very important in order to detect the complications beforehand and you become alert. So in the first, immediately after the procedure is done, first 1 to 3 hours, you have to check the saturation, pulse rate, respiratory rate, all the vital signs of the patients, if they're maintained or not, and whether when the patient is regaining his consciousness, and whether he's complaining of more amounts of cough or a little amount of hemoptysis is natural and usual after EBUS, just like bronchoscopy. But if it is large enough, then you have to evaluate and investigate. And apart from that, if there is a big amount of breathlessness present in the patient, then that needs to be evaluated further. And if the patient is complaining of chest pain, then either indicating that there is a pneumothorax or any mediastinum involvement, then that all needs to be checked. And after 1 to 3 hours, then later on, we can evaluate the patient further for any signs of hemoptysis, pneumothorax, infection. And later on in 24 to 48 hours, also similar things are to be like you have to be alert regarding all these things. And especially the patients in our setup, they quite commonly have developed fever after the procedure. So we generally advise them post procedure a course of antibiotics and antipyretic agent. So that is why they are well off once they go home. So they are not like shocked to see why the fever is developing, why blood is coming. So proper counseling of the patient after the procedure is very much required. One of our patients developed urinary retention after giving glycopyrrolate to the patient. So he had to come we sent the patient to his home and he again came back to the hospital. We had to counsel him properly that yes, this kind of a side effect can also happen. So proper counseling of the patient and to keep him in loop is very much required.
Okay, that's okay. Dr. Devraj, are you there? I can't see you.
Yes, sir, I'm there.
You are there, okay. What are
I'm
the
there.
usual post-op orders to be written after the EBUS procedure?
So first thing what we will do is to have the patient NPM for at least 4 hours. Many of the SGs also used to prefer them 10 p.m. to 4 hours, but in my practice, I usually go for 10 p.m. for 4 hours for an number one. Number two, in the patient will have some needs and to gradually normal foods, and also to patient may have fever at the evening if the procedure in the morning.
You're off again. Anyway, I think I'll go on to Patabi now. What are the tips and tricks to get the cost down for the procedure? No, but I'm asking the wrong person actually. I should be asking Dr. Unnati, or I should be asking Nishita or somebody else. Patabi is, in a beautiful, luxurious suite. But I'll tell you.
Not necessarily.
No. That was just in jest. But let me tell you one thing. All of us need to optimize the cost to the patient regarding any procedure. We can't take it for granted that everybody can afford everything. That having said that, I think it is imperative on our part to take care of the economic, the financial aspect of the patient also, and that becomes a very, very important aspect, irrespective of which place you're working in. Whether it's Royal Care, whether it is in care, or whether it's in Nair Hospital, or whichever hospital. Finance is a big aspect in our country, and we could never ever consciously ignore that. So, Pata, over to you again.
Absolutely. I think very well said, Jay. It's incumbent on us to make sure that we provide services to the patient across the spectrum. Few things here. First thing is there is an isolated lymphadenopathy, 4 or a 7, and it's only for diagnosis. Stick on to conventional TBNA. You don't need an EBUS in the first place. So that reduces your cost quite considerably. Second thing is if there is a 4L or a 7 node, and if you think that the patient is coughing a lot, you can't elderly, not very affordable, but needs an anesthesiologist or a monitoring, then go for a EUSB FNA. So you have a EBUS, shove it into the esophagus. You take care of it. There is no need for any sedation, and then you can actually go ahead and make a robust diagnosis. Only thing is inform the pathologist that it is a EUSB FNA, not the EBUS TBNA, because they'll be seeing squamous epithelium, which is not usually seen in a regular EBUS TBNA, and so they might consider that squamous epithelium as malignancy because it has no business being there. So these are the ways and means of reducing cost. Second thing is never what I'll also tell what you never should compromise on. Never compromise on scope care. And that's why I just I keep repeating it ad nauseum. Add a small portion. I'm telling you to increase the cost now, but I think that is non-negotiable. The cost for taking care of the scope and repair always added to it, and then you'll have. Then you can EBUS as a standalone. When you talk to your employer, I think this is a very useful thing to do. When you talk to the employer, never have a scope and say that this is the scope, this is the cost, and this is the outcome. You just have to propose saying that this is a IP suite. I'm going to do the whole bunch of things, and you will have to work out the cost so that you are not really struggling to ensure that there is a ROI for every bit that you purchase on an individual basis. There is this is actually you'll have to know the business of medicine, especially if you're in corporate care. You should be able to convince your employer that you're bringing new patients, you're getting more patients to other specialties, and so those are the costs that needs to be included when when they are talking to you about ROI. Be very bold, be very fair, and very clear, and say that this is not a standalone equipment. That if you, it might not make sense if you just go this particular instrument and say that this is going to be the cost, and this is what I'm going to charge. So there has to be some kind of a leverage, and say that IP suite will get you an ROA, not the individual thing. So that is the most important thing I would advise anyone who wants to venture into IP. Never use a single instrument and say that I go to look for an ROI. You will end up doing a lot of crazy stuff, including doing procedures for people who don't need it. So those are the things that you'll need to avoid. So I would think that be very selective in the cases that you're going to use anesthesia. That way, a solitary node, you don't even need to use a sedation for certain cases. Just a liberal local anesthesia can finish off the procedure. That way, you reduce the cost of the procedure. And I mean, I would again emphasize the fact that a conventional TBNA is another last art. I think that is something that needs to be used. There will be, people who will say that now how many conventional TBNAs have we used after EBUS? We've done a few. We've done quite a few of conventional TBNA even in this. That is how we reduce the cost. And I think these are the things that I think that comes off my mind when I say reducing the cost. Otherwise, I can actually say what are the things that you shouldn't really be worried about. Patients actually, if you discuss with them, they will agree to the cost if you know that the costs are going for safety of the patient, including the new needle and the scope cleaning purposes. I think yes, it's our responsibility. You can always thank your professional fees. That is one easy way of reducing the cost if you actually feel for the patient.
No, but I think this is experience talking for you. Basically, you're not looking at doing a procedure and putting down all the costing and charging a particular value to it. I think the overall picture, the larger picture has to be taken into consideration and optimize the fee for the procedure rather than going by costing. If you leave it to the so-called MBAs or other of these guys, I mean, they come out with some nonsensical figures which are untenable. I think what we need to do, as what Patabi says, is, what this is going to entail for the hospital, how much more business is going to bring to the hospital, and the overall cost has to be calculated. The intangible or the tangible costs and everything else has to be looked into, and before you make a final figure, maybe 30,000, maybe 20,000, whatever the figure may be. But the thing is, it does not always match with what you have spent on an individual. In some people, you don't charge, you don't use any of those things. As I say, sometimes when you do a regular flexible bronchoscopy and you find an ulcer or a small tumor there, and you don't need to go through with an EBUS at all. You can go ahead and do a conventional TBNA. I think all these things have to be kept in mind before you plan and actually do the procedure. Even if you're planned for it, you can decide not to do it at the end because you've got an easier way to come to the same diagnosis. I think that's about a good start for the EBUS series. I think we have covered most of the basic stuff, the anesthesia, how to go about it, the approach and other things. And I see that there are a lot of questions which have come in as to how many passes, what rows without rows. All these things will be answered in the subsequent sessions that we're going to plan out. I think so far, we have covered just about everything that is there. And I think I'll ask Mehul to come in right now and guide us through the rest of the session. I think we are done with the questions. We are done with all the overview of EBUS. I think it's been a great session. Pata, as usual, has covered just about everything, and everybody else has contributed so well. And Unnati, you don't have to feel bad. You're up there. You're doing everything. So that's good. And you also.
Just that all public hospitals should start, sir. They
Absolutely.
should start. Yes,
Absolutely. I mean, there's no doubt about that.
sir, it is free
All of
in
you
my
have done
institute.
so well.
It's free. We get the needles, everything.
No, the thing is, the basic comprehension of the entire procedure, the in-depth understanding of EBUS, when you're starting to do that, I think that has come to the fore. So anybody who listens to this particular talk will understand that there are nuances and more nuances and more. But I think you will get there. Once you start the procedure, you will learn on the job too. Everybody learns. Even Pata keeps learning and he does new things. We keep discussing so many things. And I'll tell you, it's always a pleasure to talk to somebody else who's doing the procedure. He may be a junior, he may be a senior, it doesn't matter. Knowledge is universal. I think you can take tips from just about anybody who's done these things. It's very, very unfortunate that Devraj couldn't be there all the time. I think he has fixed his video and the audio, I presume.
Yes, sir.
Thank you. That's very nice of you. Now, I think I skipped out on one. I think most of the topics are covered. I think that's about it. I don't think there are any more questions. Mehul, I think you can go on from here.
So it was an excellent start to the EBUS series, and a good opening batsman is always going to set the story ahead properly. So, Dr. Pattabhiraman, thank you very much for being the opening batsman for us. I thank Dr. Sandeep Nair, Dr. Jivraj, Dr. Unnati, Dr. Nishtha for taking out the time, and the captain of the ship. What can I say? Sir, actually, it, as you said, everybody learns. We were also learning. I just was speaking to Amita ma'am, okay, I learned a few things even after doing so many EBUS. When you hear the topics, when you hear from the seniors, when you hear from the experts, you learn from everyone around you. So the learning never stops. Thank you, sir, for being such a great moderator. And I thank Olympus and Mankind for such a beautiful platform. More than 1925 people have joined today. So a good opening for our EBUS series, and I hope to see more and more people joining us in the future. Thank you. Thank you.
It's been a pleasure. It's a pleasure on my side. It was enjoyable being with all of you people. And Patta, of course, I keep meeting him so very often. So that's a different aspect altogether. It's nice to meet Unnati, nice to meet Nishtha also, and Devraj. I wish that there was a little better connectivity at his end. Nevertheless, I think we have it has been a good start to the EBUS. And I'm sure we'll follow up with the later sessions. There'll be a lot of other people also. You can hear from the others. So audience, we can't get to see, but to hear that there were 1900 plus people, I mean, it's really pleasurable to see that there's so much of interest in interventional pulmonology and EBUS in particular right now. Thank you very much.
Thank you.
Thanks,
Have a good night.
Thank you, everyone. Thank you very much.
Thank you, sir. It was an honor and a proud privilege to be part of the first EBUS
Yeah,
workshop.
For me too, sir.
you can come back for more.
Hopefully.
Yeah,
Thank you very much, sir. Thank you, everyone. Ma'am is just joining. Just wait for a minute. She's Amita Mene is just joining. I guess she has joined through this thing.
She is becoming the delegate, actually.
Yeah.
Yeah.
So when you guys are there, we are all delegates only. We are listening only.
Okay. Amita, can you hear us? Thank you very much. I think you've been a great behind the scenes person. I think you have done a good job. Great job, actually.
Thank you. Thank you and good night.
Thank you, ma'am. Thank you.
Okay, off we go and bye-bye.
Good night.